as with almost all of the systems we've talked about, there are some specific things we should think about in terms of children and the effects of age in the renal as well as the urinary system. So we're going to look at kidney and urology pathologies found that are more specific to children, and then we'll summarize the effects of aging on the kidneys and the urinary system as well. So when we think about issues, there are two big things on the plumbing side, for lack of a better phrase. We think about the urologic system. One of the most common things you're likely to see in children are strictures. Strictures are narrowed areas in the structures that leave the kidneys. And these would either be urethral or ureteral. Now, ureteral strictures are fairly common in children, and this can be something that a child is born with and then manifests as the child enters their early years, but usually is not something that just happens all of a sudden. And so with the ureteral stricture, these can either be unilateral or bilateral. And and if it's a unilateral stricture, the child could have pathology in only one kidney, and as a result, then any kidney effects would be masked. If it's bilateral, then the child is going to manifest with chronic kidney disease if we don't catch it and relieve that stricture. And that's the beauty of this. A ureteral stricture can be bypassed. And once you bypass that stricture and you provide free flow from the kidneys down into the bladder, the child continues to grow and does well. A urethral stricture is obviously from the exit from the bladder itself. Urethral strictures are usually fairly obvious because the child either doesn't urinate or has an abnormal urinary pattern. So they might have to get the bladder very, very full before there's enough pressure in the bladder to force open that urethral stricture. Again, relieving the stricture takes care of the problem. Unrelieved, it makes sense though that if either a ureteral stricture or a urethral stricture increases the probability of infection within the urinary tract. And so that's, again, one of the things you would want to be watching for. The other piece that I think you'll see more in children are a couple of immune glomerular diseases or glomerulonephritis. The first of that is post-beta hemolytic strep, which is group A, and this actually causes a glomerulonephritis. Generally with this post-beta hemolytic strep, a child presents with a glomerulonephritis 1 to 2 weeks after usually a staph or a strep infection. And this could be up to 6 weeks, but usually it happens within a couple of weeks after having a staph or strep infection, an upper respiratory or a skin infection. Because this is a glomerulonephritis, you know that there are circulating complexes. And these circulating complexes present themselves to the kidneys. This can cause the rapid onset of nephritic syndrome. So remember, we talked about nephritic syndrome earlier. So what you would watch for then in a post-beta hemolytic streptococcus A glomerulonephritis is peripheral edema, hypertension, oliguria, and proteinuria. Now, one thing, and not completely sure why, but this glomerulonephritis tends to be less severe if this was an upper respiratory infection and or if protein less than 1.5 grams per day was being excreted. The protein makes sense to me. Now, why, if it's an upper respiratory infection, I've never found a good explanation for that. So if anyone finds one, shoot it to me. But we do know the protein makes sense because the less protein you put out, the more intact or the glomerulus would be presumed to be. Therefore, it is less severe. Another disorder that you see primarily in children, although hemolytic uremic syndrome has been known to occur in adults, it virtually always occurs in children. And this is due to E. coli 157. There's also a 104. But the E. coli produces a toxin, and this is the Shiga toxin that's produced by the E. coli bacteria. This toxin presents itself to the kidneys and causes lysis, breakdown of the glomerular capillary cells, and damages that basement glomerular membrane. Because of the lysis of the cells and damage to the membrane, this stimulates the inflammatory cascade. With the inflammatory cascade, once again, remember you have to remember that there's a coagulation part of that. So what happens in the glomerular arterioles is that they become clogged with platelets as well as fibrin clots. So this causes a thrombotic microangiopathy. Because of the inflammation and the changes in the arterioles, this manifests as hematuria, proteinuria, as well as damage to the red cells. And the damage to the red cells actually happens in the periphery. In the periphery, then, these damaged red cells are broken down by the spleen. This then leads to additional fibrinolysis and a thrombocytopenia. So what happens then in this HUS, this hemolytic uremic syndrome, is it is characterized by a hemolytic anemia. Remember, damage to the red blood cells had to be lysed by the spleen. A thrombocytopenia, the arterioles were clogged with platelets and fibrin clots, as well as acute kidney injury. So this is a fairly typical presentation of that Shiga toxin produced by the E. coli, and it causes hemolytic uremic syndrome. Now, there is also an atypical form of HUS. This is a rare genetic disorder in which there are defects in complement and complement regulation proteins. But again, that is very rare. Most of what you're going to find is the E. coli-related HUS. Now let's turn our attention to elders. So the first one that we would think about is in the plumbing system, and this is prostatic hypertrophy. Now, prostatic hypertrophy may be benign or it may be cancerous. Now, I put benign in quotes, not because I quoted it directly from someone and I need APA format, but there is nothing benign about this. Prostatic hypertrophy can be extremely dangerous. And prostatic hypertrophy is the benign form is generally linked to the imbalance between androgens and estrogens as a male gets older. Now we know that every male, just as every female, has both androgens as well as estrogens, has male sex hormones and female sex hormones. As the male ages, the production of the male sex hormones, the androgens, begins to decrease, but nothing happens to the estrogens. They continue to stay fairly level. As a result, that's why there's an imbalance. So that imbalance actually causes the prostate to grow larger. And that prostatic enlargement then is what we call benign. Now, if it's cancerous, one of the things we look for is that cancerous has, in some men, been linked to males that have a family history of BRCA1 and BRCA2 breast cancer in female relatives. If they have a family history of BRCA1 and BRCA2 breast cancer in their female relative, their cancer is 4 times more likely to be advanced by the time they're diagnosed. Cancer in the prostate can also be caused by asbestos exposure. Now, prostatic hypertrophy, whether it is the benign form, which, as you know, I don't really think is benign, or cancerous, it's non-cancerous, leads to overdistension of the bladder and therefore hydronephrosis, and this causes a bilateral hydronephrosis. If this happens quickly, this would be a post-renal acute kidney injury, because this is going to increase pressure in Bowman space, and as a result, this nephrosis is going to cause an AKI. This potentially can cause an acute kidney injury, but rarely causes chronic kidney disease. However, it can, especially in someone who has a fair amount of hypertrophy, but they're still able to void. Manifestations that you should be extremely alert for in BPH include overflow incontinence. So this is what's happening. The bladder outlet is being severely restricted because of the prostate gland. And so the lumen is therefore narrow. However, the bladder just keeps on filling and filling and filling and filling and filling and filling. Well, we know that bladder is a muscle. That detrusor muscle has the ability to expand quite a bit. But as it continues to expand, that fluid, that urine, is like a balloon, and so it's going to be under high pressure. As long as there's a way to get some urine out through that lumen past the obstruction, that's where the overflow incontinence frequently comes from. That's also where the frequency would frequently come from, that the bladder is pretty full, and so they're going small, frequent amounts. Now, it makes sense then that the other thing to be looking for would also be urinary tract infection, because that urine that's been sitting in the bladder is more likely to become infected, and that poor tone in the bladder is likely to facilitate infection than if they were able to empty their bladder. Now, other manifestations that the male may complain of might include abdominal pain. The bladder may get full enough that they're having trouble buttoning their pants. They may even have back pain, but that has to be pretty advanced by the time they get there. It would not be terribly uncommon if this has been fairly long-standing, so for several weeks, that when they manifest, not only do they have an extremely overdistended bladder that may be infected, but you may actually see a bump in their serum creatinine level that should come down once you relieve the pressure and you relieve that distension. So what are some of the other effects on aging? Sorry guys, but prostatic hypertrophy is one of the effects of aging. We know that as we get older, we have a decreased number of nephrons, especially our cortical nephrons. We keep our juxtaglomerular nephrons, but we are generally able to maintain a healthy GFR. It may drop a little bit, but we certainly don't develop chronic kidney disease. However, we are very alert for chronic kidney disease in our individuals who are older, because they do have a slight decrease in the number of nephrons, those cortical nephrons, but remember, they are also likely to have atherosclerosis and therefore resulting hypertension. They may have diabetes. So the comorbid conditions that also are more common as we age are also affecting their kidney function. The negative effects as an individual, if they do have negative effects, you would see this in the glomeruli, because they may develop some level of sclerosis and hypertrophy of the glomeruli. With tubular function, this is something that even with the good number of nephrons, you may see a less efficient reabsorption of glucose, bicarbonate, sodium, and less efficient secretion of potassium. So as a result then, with some of the changes of aging, you may be more alert to glucose in the urine, more likely to develop acid base, as well as fluid and electrolyte disorders if their kidneys are stressed. As we get older, we have a reduced ability to concentrate our urine because of the changes in reabsorption and secretion. So remember, we talked about a specific gravity of 1. So if an individual who is older is more likely to have, because they can't concentrate their urine, you would expect that their specific gravity might normally be closer to that 1 than someone who is younger. Because of the changes in our circulation, the changes in the glomerulus, we have an increased probability of adverse drug reactions, and specifically we talked about nonsteroidal anti-inflammatory nephrotoxicity being more likely to occur in young individuals, in elders than in young individuals. If we look at plumbing just sort of by itself, we talked about the effects of prostatic hypertrophy in the male, but we also know that as we get older, we tend to lose muscle tone. As a result, then, there is an increased incidence in bladder frequency, urgency, and nocturia. What's very important, though, is incontinence is not a normal variant of aging. Incontinence should always be investigated because it may be the first sign of a urinary tract infection. Urgency may be a sign of urinary tract infection, or could actually be in nocturia, a beginning sign that the kidneys are beginning to fail some. And when they sleep, they circulate their kidneys better, so they have to get up in order to go to the bathroom. So if we look at an overall summary of everything we've talked about with kidney and urology pathology, I think that the physiology of kidney function is a fairly elegant simplicity. But there's nothing simple or straightforward about what happens to in the kidneys and how that affects homeostasis. When we have an alteration in pathology, it affects the processes of filtration, which remember is at the glomerular level, and then also reabsorption, secretion, and excretion, which are at the tubular level. Pathology within kidneys is due to primary as well as secondary to other diseases, so we want to be able to differentiate those. And I cannot say enough, if you alter the physiologic function of the kidneys, you will affect the homeostasis of numerous systems. Thank you for your attention. If you have any questions, give me a buzz.